Our next speaker is a cardiologist. Excuse me. Dr. Joshua Buckler is a clinical cardiologist and director of the Minneapolis Heart Institute's telehealth program, which has been at the forefront of providing telemedicine services to outlying areas since 2014. After finishing medical school and residency at the University of Michigan, Dr. Buckler completed his training at the University of Washington in Seattle and went on to practice in the region for 9 years, eventually becoming Chief of Cardiology at Swedish Medical Center. Wishing to return to the Midwest, Dr. Buckler and his wife, along with their 3 children, moved to the Twin Cities, where he joined Minneapolis Heart in 2018. He assumed the role of Director of TeleHeart Services in 2022, where his interest in technology met his passions for customer service and quality care. His clinical interests are in atrial fibrillation and telemedicine, and practices out of Abbot Northwestern in Chaska, Waconia, and Glencoe offices. Let's welcome Joshua Buckler. It's all right.
All right. I think I need to talk to the microphone because of the remote. Well, thanks for having me. I really appreciate it. I want to take a quick second before I get into the talk, and I'm always amazed at the survivor stories, and every one of them is unique, and so much of what comes down to sort of a good story has to do with really, attention from a provider or from a patient or from a patient's family, recognition of the seriousness of what's going on. And I'm amazed at two instances which I've run across over my career. One of which, I was telling Megan this, that I cannot tell you how many patients I have seen who I see in their 40s, 50s, 60s, 70s, whatever, who come to me with a new echo that shows that they've got severe aortic stenosis. And I say to this patient, I said, well, how long have you known about your murmur? They said, 3 days. I said, wait a minute. This has been going on for 30 years. I said, yeah, no, I've seen my doctor in and out, and everything's been fine. And they told me everything's normal. And I tell them, well, unfortunately, this has been coming on for a long time. And so I always reinforce with our trainees that anybody over the age of 40 should get an echo who's got a murmur, because you'll find things. And a quick, really fun story that I'll tell you it's got a happy ending is, she mentioned that I was in Seattle for many years. And when we were there, there was a bartender by the name of Murray Stetson, who is really the godfather of the modern craft cocktail movement. This is a guy who had found a old cocktail book from the Detroit Athletic Club from the 20s, actually, and had started making sort of these really complex craft cocktails, and really started at the Zigzag Club in Seattle. And he was working in and out of various bars over the years, and he was on his way home one day from work about 2 o'clock in the morning, and he all of a sudden felt terrible and collapsed. And he was found down, and he was taken to the emergency room, and it turns out he had severe aortic stenosis that was unknown. It's unknown partly because he had no insurance, and he hadn't seen a doctor in years. And unfortunately, because he had no insurance, there was no way to pay for his surgery. So the bartenders across the country got together and actually all chipped in and had events nationwide for Murray, because he had taught so many people the craft of cocktail making. And so to this day now, he's survived. He survived and has done well because of the gratitude and the goodwill of all of the trainees over the years. So I always think about that story, and I think about the importance of making sure that people see their doctor, get good care, which brings us to my talk, which I entitled House Calls, Entering a Modern Era. But really what this is a quick look into really what's becoming a game-changing technology, and that is with telemedicine. Human beings have been communicating long distances for forever. We've gone from smoke signals to letter writing, and then with the advent of electricity and the radio, we moved on to telegraph, and then telephone, and then we even have early video conferencing here, as you'll see from the 60s, with this is actually, I believe, the president of Sweden, and obviously we've continued to evolve from that point. And even telemedicine by itself is not an entirely new idea. There were some early video conferencing ideas from Thomas Edison from the late 1800s. And you'll see here on the cover of Radio News from 1924, this young boy is getting his sore throat evaluated, probably for strep throat. Interestingly enough, 17 years before penicillin would even become available. But we recognized early on that this could be of value. And technology has continued to advance in the communications realm over the years, but not everyone would agree that every single change has been for the better, as Twitter has brought us to realize. So the question is, how did we get from this point where we have a doctor at the bedside examining a patient, and he probably came by carriage to perform that house call, to the other side here where we see a man getting his cough evaluated from a doctor who was 100 miles away on his $1,000 smartphone. And it turns out there's a couple key things that have allowed us sort of to evolve and progress in this arena. So obviously the first one is technology. We talked about electricity, we talked about radio, and the birth of the internet obviously changed. But really it wasn't until the early 2000s where things really started to change dramatically. The first thing that really helped advance telemedicine really was the increasing the availability of broadband. Broadband in the community locally as well as across the rural areas. The speed of internet, the bandwidth that we could provide that allowed us for simultaneous video and audio transmission. Similarly, 4G, I don't know if you've ever seen sort of the discussions about sort of where we've gone from 2G to 3G to 4G, but it's literally going from, caveman level to airplanes. I mean, in that very short period of time. 4G allowed us to transmit wirelessly really high bandwidth video and audio that allowed us to do telemedicine visits, amongst many other things like streaming your favorite Netflix show wirelessly. And then 5G and then 6G eventually will bring even higher levels of transmission. Webcams have become increasingly ubiquitous. Everyone's got a webcam at home, or 2 or 3. The quality of the cameras have improved. And then medical technology itself has actually also allowed us to advance telemedicine. As you can see here, this stethoscope here is the Bluetooth-enabled stethoscope that we use for remote exams on patients, which I'll get to later. And then the pervasive nature of different medical technologies that are consumer level for home monitoring of various vital signs and electrocardiograms and whatnot. But interestingly enough, it wasn't just the technology advancing, but it really was societal influences over the last couple of years that have really started to accelerate this dramatically. So social unrest and the move away from the cities has really pushed people towards seeking out sort of remote interactions. There's this little virus you may have heard about that made people isolated, and I think it's really changed things dramatically. And then more recently, even inflation has made travel more expensive, and so patients have wanted to not try to come in as often as they need to. One of the biggest changes, and probably the thing that has created the greatest inflection point, was that the Medicare changed the rules around telemedicine. We had been slowly growing the telemedicine arena up until the pandemic hit. And then when it became clear that we were shutting down hospitals, we weren't able to get patients in, we were told everyone to lock in and stay shelter in place, Medicare realized very quickly, and to their credit, the government doesn't do many things quickly, but they recognized very quickly that we needed a change. And they lifted a lot of the restrictions. Up until that point, really, to provide remote services, the patient had to be a certain distance away from your center. They had to be at a medical facility that provided them with audio-visual interaction. They had to have a pre-existing relationship with that provider. So there really were very tight restrictions on how this could be delivered. And our initial program was based off of these rules. Even audio-only visits were restricted. And so what happened was they changed all of that across the board. I mean, and to their credit, this really was probably the key defining moment. We'll be talking about this for decades to come. And so what you'll see here is this was an analysis done really in very, very early 2020. It was published that looked at the size of the market in telemedicine nationwide. And what you'll see here is that in 2019, the market was about $6.6 billion. This is a sizable market for just about any industry. And the projected growth was about 15% per year. And they expected that by about 2027, we'd see a market of about $20 billion. Well, that all changed. And in 2020 alone, we hit nearly $20 billion. And now we're looking at a market by 2030 to upwards of $100 billion in terms of care and technology and the resources needed to drive this program. And so it's accelerating very, very fast. And this really could not come too quickly for the folks in rural America. we've seen a steady decline in availability of healthcare in rural America. We've seen consistent hospital closures, and this is even with federal designations for what we call critical access hospitals, which have allowed for increased reimbursements from Medicare and for more staffing flexibility. With this, even with those benefits, we've seen continued steady decline. And it's not like people in rural America have less disease. And in fact, for the 5 leading causes of death in the United States, the folks in rural America actually have a higher incidence of death, probably because they don't often get the care that they need. And the population in rural America is aging faster than it is in the urban centers. And they have to drive farther. So now we've got this population that's getting older, faster. They have a higher death rate, and they have to travel further to get care. And so all of these changes for telemedicine could not have come at a better time. And so you'll see here a map of Minnesota, for those of you who are from here. What you'll see is, we know that we have very few concentrated urban centers, but really the majority of the state is covered by rural hospitals. And the vast majority of those are critical access hospitals, which are small hospitals, usually 5, 10, 15 beds that exist in these areas, and they're really only kept afloat because the government has decided that it's critical to have these available for people in those areas. And so in Minnesota specifically, we have issues around an aging population. We have a large area covered by critical access hospitals, which really don't offer, there are no cardiologists in these facilities. We have a few highly contracted urban centers, but they're where the patients are. And then we have an aging physician workforce, which I didn't really get into today. And so in 2014, my partner Mark Newell, who spoke here last year, started the MHI TeleHeart program. And really what this was bringing telemedicine for cardiology to a lot of these outlying areas. And at the time, it operated under those strict restrictions that Medicare brought. So we had to have patients come into the office. They had to be in specific facilities, and they had to be a certain distance away from Minneapolis. And we started with 3 sites in New Ulm, Olivia, and Faribault. And that year, first year, we saw 100 patients. The goals of the program really were, we wanted to be able to bring our expertise to the outlying areas. And we wanted to really become sort of a integrated system that allowed both virtual care and in-person care, and could try to bring as much care remotely to the patients as possible so that the patients didn't have to travel as much. All the while, we want to maintain our triple aim of maintaining the quality of care, maintaining a positive patient experience, and overall at a reduced cost. Less travel, hopefully less testing, because we were able to intervene and get on top of the patients earlier, so that we avoided unnecessary testing. And from this, the MHI TeleHeart program has really become the national thought leader in telecardiology for sure, and really in telemedicine. Mark Newell often just asked to speak at national meetings on the program. The program was very well received early on. We had really excellent feedback from patients and providers alike. And this is the state of our current program. We currently have 16 programs in 13 locations. So there's one location down in Medelia, down by New Ulm, that's not on here. But we provide subspecialty services at 3 of our sites, and we're continuing to grow. We currently are in the process of building out sites in western Wisconsin as well as other areas within the state. And the TeleHeart program itself has continued to grow. As you'll see, that dip in 2020 really came before the rule changes, because we had to have patients in person at these remote sites, and that was limited at the time. But for the first time ever, we crossed the 1,000 patient threshold, and we expect to grow very fast from this point forward. So you'll see this is kind of what our TeleHeart setup looks like. This is not our system, but basically what it is it's a patient comes for a visit, and there's actually a camera and a video visit, and there's a nurse there that helps facilitate the visit. We'll get more into details. And then now, for the first time ever, we are now starting to do inpatient consults. It seems like a natural progression, but really had not been done up to this point. We're piloting this with New Ulm. We started in December of 2022, and we're going to rapidly expand across the state. You may or may not be aware, but after the pandemic hit, we've really never recovered, and we've had a hard time getting patients in and out of hospitals. There have been backlogs for post-hospitalization recovery units, and so what's happened is we can't transfer anybody. So you end up in an ER in Faribault, and you've got something serious, you could be there for 3 days before you get transferred. And so we're trying to focus on keeping patients as locally as possible. So for things that do not require quaternary care, we're trying to keep them close to home. And so what does a teleheart visit for us look like? Well, you basically come into a visit in your local facility just like you would for any other visit. You check in, you get roomed by a nurse or by a medical assistant, vital signs get taken, they go through your medications, and then the cardiologist comes in on video. We're able to perform an exam. We had that Bluetooth-enabled stethoscope, as I showed everybody early on, and it's not perfect. It's not as good as touching somebody, but it provides a lot of diagnostic data that can help, and it's better than us having to have the patient drive long distances to come to be seen. And then the care plan is created between the patient and the provider, and then related to the primary. So being in person in the office. A virtual visit, which are those telephone and video or your smartphone visits, involve a pre-call visit from by a smartphone or computer at the time of your visit. There's no exam during these visits, but again, it can help us fill in the gap of some of the care that needs to occur, and then wrap up with a care plan created. Oh, this did not come through. Shoot. Oh well. Well, basically, sorry, there's supposed to be an animation here. I had it all fancy. So basically what happened, so advantage of teleheart really is that you're close to home, you don't have to travel, you get high quality care, and really hopefully decrease the amount of overall cost to the patient, both from a travel standpoint as well as avoiding unnecessary testing. The disadvantages is it's not the same as in person. We all recognize that, but hopefully the trade-off with being able to be close to home fits or makes up for that. There are not all the services available, and we don't have cardiac surgery, and we don't have all of our heart failure providers available remotely. Although we are trying to grow the program and try to bring in more subspecialists. And some people just don't feel the value isn't there. Again, I do think that the trade-off of being local versus not being in person, I think it kind of balances itself out. But we recognize it's not perfect, but we do think it serves an important purpose. Well, see, now it works. Well, anyways. So the question is, why does this group care about this? I don't know of a group that's probably more in tune with the idea of knowing that without early detection, that the outcomes can be much worse. And so early detection, proper preventative treatment, appropriate monitoring, and communication with providers is really critical. And telemedicine and really teleheart really provides all those things. So the whole idea is we want to be more available to people in ways that makes it easier for them to get care, and they get care more regularly. And so we strongly believe that the telemedicine program and teleheart specifically can do that. And so where are we going from here? And so what's really interesting is that technology is changing rapidly, as we all know. The upper corner here, this is TytoCare. This is actually a program that we're going to be using very soon within our system for our remote stethoscope. And this is actually a device you can actually even have at home, and it comes with different dongle add-ons. This is an otoscope that can look at the ears. This is a stethoscope that can listen to heart and lung sounds. This is a laryngoscope that can look down the throat. And so there are some programs where you can actually have this in the home and examine. This is actually a company called Caption Health, which we actually were involved with early on. That is a company that uses artificial intelligence to obtain cardiac ultrasounds. And the company always showed the example, as they would demonstrate this, they would pull a janitor in or out from the hallway, and hand them the probe and ask them to put the probe to their chest. And through prompting through the computer with green bars showing how they're doing and how to adjust the probe, they were able to obtain themselves a diagnostic level cardiac ultrasound without having to have had any training before. So we're looking forward to being able to use this by sending these to patients, having them do their ultrasounds at home for monitoring, and hopefully avoid having them come into the office. This is an area that I think is really neat, is that holographic conferencing is coming down the pipeline. There's a company called Proto, which is currently making these boxes. There's a full size or a small size. And I think we'll see this, and you'll be able to have a doctor sort of, look like they're more physically in the room with you. And then virtual and augmented reality certainly is going to be critical for the advancement of all this technology. And so what will telemedicine look like in the future? We expect it to be a more immersive experience. We expect there to be through holographic technology or through virtual or augmented reality. We expect it to be much more like you're in the room with the physician. We expect there to be 24/7 availability. We currently have, as I mentioned, outpatient visits during daytime working hours, which is the same thing with the inpatient, but we'll get to the point where we actually have availability around the clock for care that can occur. Improved diagnostic tools. As I mentioned, we do use the Bluetooth-enabled stethoscope, but we expect there to be additional real-time monitoring that can occur down the road. Remote surgery, maybe not aortic surgery, I don't know, we'll see. But I think the point where we'll be able to provide more services more remotely will come. And for continuity, one of the things that has been a challenge is, especially for people living far away, is you may not always see your same provider because you got to get who's there that day. And so we expect this to allow you to have your doctor follow you closer to home as people transition away. And with that, I'll leave you all. Thank you.